I'm assuming all of you have some exposure to targeted lung health check. Is there anybody who is not serving an area which does not have a TLHC program?
Which area is that?
I'm in the United States.
The country as a whole has a plan.
We have a plan.
A plan.
A plan.
Very good, very good.
I work in Saudi Arabia, so we don't have a screening doctor. Although there is a trial starting.
Yeah. Interesting. Good. So the fancy name is that because we don't like to scare people away. Smokers feel already guilty that they've done a bad thing and they don't want to come up and have scans. They don't even come and have a chest X-ray. They don't go see the GPs. So we had to find something which was catchy, which would get them in and catch other things as well, other than cancer. So that's how part of the name has ended up as a targeted lung health check program rather than this is a breast cancer screening program, which is what the breast cancer screening does in that sense. So whenever the NHS is tasked to do something like this, then you have NICE telling us, dictating, rightly so, is this something that is possible? Is it the right thing to do? Are the finances going to add up? So you need to work out what the cancer-specific mortality is, all-cause mortality, quality of life you're achieving, and are you going to do a targeted screening or not? So all of that goes into that equation. So the background to all of that is also the fact that as surgeons, you know the 5-year survival figures for stage 4 lung cancer is abysmal. We know, fortunately, what causes the cancer in most of the patients, so you can target it. And the initial trials which were done 50 years ago, the Mayo Lung Project and the CHECK trials, which were using a chest X-ray to identify lung cancer, was next to a waste of time, really. So gradually, in the 90s, the plan was to do low-dose CT scans, started in Japan, America, some European centers. The first largest trial was set up in the US, the National Lung Cancer Screening Trial, which looked at 53,000 plus volunteers who were in the age group 55 to 74 and had a 30-year back history. So they had 3 annual screening CT scans randomized into the 2 arms. And this is probably the only trial which has clearly shown there are fewer deaths in the screening arm over a 6.5-year median time to follow-up. i.e., they saved 1 life for every 320 patients they were scanning. If you compare that with breast cancer screening programs, you need to scan or do mammograms on 520 ladies to save 1 life. The reduction in all-cause mortality in the CT arm was also statistically significant. So that is the NLST trial. The other trial which you probably hear commonly about is the Nelson trial, which is the Dutch-Belgian trial, which looked at a smaller group of people, about 15,000 to 16,000 patients. It showed the lung cancer mortality was lower at 10 years. It was even lower in women. Maybe you shouldn't even look at screening when maybe you target the women more. Then there's the MILE trial, which is the Italian trial, which suggested there was a 39% reduction in the lung cancer mortality. They were saving more lives for fewer patients scanned. Whether they smoke more, I don't know in Italy, along with the nice espressos. UK not wanting to be left behind, did a trial not so long ago between 2011 and 13. Over a 16-month period, they recruited 4,000 patients from invitation of more than 25,000 patients. They divided them into 2 arms, CT screening and no CT screening. Unfortunately, our trials did not demonstrate a significant lung cancer mortality benefit. The incidence in the trial arm was also not significant. The number of deaths in the screening was lower. Of the 100 patients who died, 42 were in the screening arm. But what the trial definitely showed, what we probably knew already, is the fact that higher proportion of early stage disease was being picked up in the screening arm. A meta-analysis followed using the 3 big trials that we talked about. This 9 trials were pulled together, and the agreement was that we would start a pilot program of lung cancer screening, which was set up in different parts of the country already, but they were all gradually merged into one single program, which was signed off only last year to have a UK-wide targeted lung cancer program. So that's where we have arrived. And Birmingham was a latecomer to the party. We came quite late, and this is the pooling of the data from the 9 papers I put together, and that dotted line kind of says, yes, it's worth doing, and the number of trials which said it favored screening was just to the side of that dotted line, and that's where we landed up. So the other things to also think about while you're doing screening is, for example, the TLSC, it's targeted. You know a group of patients that you're going to get results out of. The NLST has already told us you're going to save at least 20% cancer-specific mortality and 6% all-cause mortality. Every time a patient comes to TLSC program, they are seeing a nurse, they get education about smoking, quitting, all of that. So that is another advantage. The other spin-off is the fact that there is a CT scan which shows lots of other things other than what it's meant to pick up. And we have 19 pathways to deal with the incidental findings that come out of the TLSC program in Birmingham. So that is the scale of things that it can show. Some of that is a wild goose chase. You're going down a route where you're putting patients through anxiety, not knowing what is going on, their lives are on hold. When they're on that program, if you have a scan saying nothing wrong, then that's fine. But then you end up with having a 3-monthly scan or an annual scan. That is a huge amount of stress you're putting on these patients. Is it worth it? We also decided it was worth it, but we'll have to see how things proceed in the years to come. And it is expensive. The number of people involved in the screening program to get this running, we worked out from the breast cancer screening program, it is very intensive, very complex to run. And we are jumping into a lung cancer screening program, which is a beast. Once you start it'll start consuming everything that is there. We start off with 1 PA for a physician, 1 PA for a radiologist, and now, by the time we got the whole of Birmingham covered, it just is not enough. Am I taking away my services from somewhere else to do something which may not actually give some benefit? So there are things that you need to think about. Are we picking up things which would have come slowly anyway and would have been dealt with? Like the first patient we saw, the bronchialveolar, it's going to be lingering on for a long time. It's not going to cause much damage instantly. So are we just getting the lead time bias, which has been a common story with the breast cancer screening program? And like I mentioned earlier, should we just screen women? Don't waste time on men. There's not actually a huge benefit that some of the trials have shown. So there are all of these things to think about, but the first slide I showed you is the abysmal 5-year survival rate for stage 4. I think that is the driving force for what got us here, and that was the reason why Barbara and I, one of our thoracic surgeons here, worked on this project to get it running in Birmingham. So just to give you, I don't know how many minutes more I have, I can give a quick run through of what a TLSC program looks like, or what we do in that. That's still okay? Yeah. So we pick patients 55 to 74 year. They are from GP databases. There are some clever programs that we can run to see who are the at-risk populations. So all of those people are targeted practice by practice, and we get them invited. We have vans which go around the city. We park them in Asdas and elsewhere, get patients in to be scanned. They don't all get scanned, so they are seen by a nurse who assesses them for their risk, gives them advice about smoking cessation, does a spirometry, and if they are a low-risk patient, they don't get a scan. If the questionnaire identifies that there are things that a GP can help with them, get them onto the COPD clinic, get them on a path to optimizing their care, they will get that sorted. And the high-risk patients will go on to have a lower CT every 2 years. In the past, when I started, I'm sure I've missed 1 million bronchial carcinomas, those tiny little ground glass patches, and I call them scarring. Now I'm worried about them and I'm calling them in for repeat scanning. We are helping ourselves by using computer-aided detection to find these nodules. You have a platform whereby you can input the data, so it tells you what the growth of the nodules are, what the Herder score, sorry, not Herder, the Brock score is. And we also are meant to have access to prior imaging, so we can compare and ignore the nodules which are present before. The reports that you see for TLHC scans will be very structured. They'll look like a lab test rather than a standard report that you see from the radiology department. It will tell you clearly what to do. It's red, orange, or green, and then it tells you what you do after that. And like I said earlier, there are 19 incidental pathways which is created in the industry for us, unfortunately. So anything that's more than 300 cubic millimeters in volume, greater than or equal to 8 millimeters, or have a Brock score greater than 10% will get into the next stage of the lung cancer pathway. Anything that's indeterminate will go through, as prescribed by the program, into either a 3-month follow-up or a 1-year follow-up. So with our partners, we have additional 2 sections where there are critical findings like picking up aortic dissections or aneurysm. We won't see a dissection, we'll see an aneurysm, so we can pick that up. And again, there's a bit where we try and not flood the screening review meeting with too many patients to look at. So you have a system of structured reporting. The screening review meeting happens weekly. You have a respiratory physician, a radiologist, a TLSC coordinator. You have sometimes the radiographers who do the scan or somebody from the scanning company who does it. We have outsourced all our scan reporting outside the organization because we thought we couldn't cope with it, and therefore we will have a representative from that organization as well in that meeting. At the end of the meeting, we decide what we do, like I explained earlier. The structured letters go out to the patients so everybody knows what's happening.